Precision oncology is an absolute game changer. The idea of tailoring a treatment to a tumor's specific genetic weaknesses, it's incredible. But what happens if only a tiny fraction of patients can actually get it? Are we accidentally creating a two-tiered system for cancer care? Well, that's the big question we're exploring today. And here is the number that really hits home. Right now, fewer than 10% of cancer patients around the world have access to the kind of comprehensive genetic sequencing that these advanced treatments rely on. That is a staggering gap. This is what the paper calls the precision oncology gap. It's a system where, right now, we basically have two very different standards of care, and that's a problem that really demands a clever solution. And when you look at the numbers, you really see why this gap exists. Comprehensive sequencing is incredibly powerful, no doubt, but it costs thousands of dollars. And as we saw, it's just not available in most places. On the other hand, you have these much more affordable biomarker tests. They're already common in over half of clinics. So the real challenge is, how do you build a smart system that works with the tests people actually have access to? So the researchers behind this paper decided to tackle this head-on. They didn't try to design something for a perfect, futuristic world where everyone gets a $5,000 test. Instead, they built a system specifically for the world we live in right now, a world full of messy, incomplete data. And I love this quote because it really gets to the heart of their philosophy. The goal here isn't some all-knowing AI that spits out mysterious answers. It's meant to be a transparent, helpful co-pilot that assists doctors, giving them clear, reasoned guidance based on whatever data is available. So, how does it pull this off? Well, it all comes down to three simple but really powerful rules. First, as we've said, it's built from the ground up to work with patchy, incomplete data. Second, and this is crucial, it knows what it doesn't know. If the data is sparse, it actually puts a cap on its own confidence. And third, every single recommendation it makes comes with a receipt, a totally clear explanation of how it reached that conclusion. Okay, so let's get into the nuts and bolts. The paper calls the mechanics gates, and they're basically a series of rules that smartly and safely adjust treatment recommendations based on specific pieces of evidence. First off, the system's default setting is be careful. For a really potent class of drugs called PARP inhibitors, if there isn't clear evidence they're going to work for a patient, the system automatically applies a penalty, which lowers the drug's predicted effectiveness. It starts with caution. And you might be asking, okay, what exactly are PARP inhibitors? Well, they're a type of targeted therapy that can be incredibly effective, but, and this is a big but, they usually only work in tumors that have very specific weaknesses, often related to genes like BRCA. That's why the system is so cautious about recommending them without proof. But here's the really clever part. The system isn't just cautious, it's also responsive. If one of those affordable tests comes back positive for a key biomarker, like HRD, it triggers what the paper calls a rescue. It sees that positive evidence and immediately removes the penalty. It adapts. And it's not just for PARP inhibitors. The system has a similar, super clear step-by-step logic for immunotherapies. It has a clear hierarchy. First, it checks for a high tumor mutational burden, or TMB. If that's not there, okay, it checks for another marker called microsatellite instability, or MSI. And if that's also not there, it checks for a more moderate TMB score. It's a completely transparent process. And this right here, this connects back to that core principle of being honest about what it doesn't know. The system literally grades the amount of data it has for a patient, from L0 for very little up to L2, and its confidence is directly tied to that grade. If it only has L0 data, it will not allow its confidence to go above 40%. It's designed to prevent overconfidence. Okay, so the design is elegant, it's cautious, it sounds fantastic on paper. But the real question is, does any of this actually work for real patients? Does it predict what will happen? Let's look at the data. For their first test, the researchers looked at endometrial cancer. This is a cancer type where those affordable biomarkers, TMB and MSI, are already known to be pretty important. And the results were just striking. Patients who had high levels of these biomarkers, the ones the system flagged, had significantly better survival. A hazard ratio of 0.39. What that really means is their risk of death was reduced by about 61%. That is a huge signal that the system is picking up on a real biological effect. Now, any good scientist knows you need a control. You have to prove you're not just getting lucky. So next, they ran the exact same analysis on colorectal cancer, a disease where these particular biomarkers are not expected to have the same powerful effect. And what did they find? Absolutely nothing. No significant difference in survival. And you know what? This is actually fantastic news. It proves the system isn't a fluke. It's correctly identifying a specific biological signal that's present in one cancer but not the other, just like it's supposed to.
So the clinical validation looks really solid. But what about that other core promise? The promise of safety, especially when you're dealing with the messy, incomplete data you find in a busy clinic every day.
To figure that out, they ran a safety audit using data from almost 500 ovarian cancer patients. And in over 98% of those cases, the system did exactly what it was designed to do. It defaulted to its cautious part penalty. It put safety first. And this is maybe even more impressive. In that exact same group of nearly 500 patients, how many times did the system apply one of its competence caps? Every single time. 100%. It never, not once, allowed itself to be overconfident when dealing with real-world data. And this table just brings it all home. It really shows you the before and after. Standard practice is often kind of vague, right? Consider this drug, or this patient may benefit. This system replaces all that ambiguity with clear, quantified guidance. You get a specific number for efficacy, a hard number for confidence, and a clear reason why. It turns a subjective art into a more transparent science. And when you zoom out, you realize this is about so much more than just one cool piece of software. It's really a new philosophy for how we should be building AI for medicine. It's about designing systems that are equitable, safe, and transparent right from the very beginning. Systems built for all patients, not just the 10%. And that really leaves us with a pretty big question, doesn't it? Instead of always building technology for a perfect world with perfect data that doesn't exist yet, how can we apply this same philosophy of being cautious, transparent, and equitable to solve other really pressing problems? It's a question that goes way beyond just medicine.